Today we're going to talk about Cancer Staging 101. It will be a brief review on cervical, endometrial, and ovarian cancer staging as part of the CREOG Video Project. The goals and objectives for this talk are as follows. First, we'll briefly review the risk factors and epidemiology of the three most common gynecologic cancers. We'll then discuss the Figo and TNM staging criteria for each of these three cancers and compare and contrast them. And then to practice, we'll review a CREOG practice question from TrueLearn on cancer staging. The first cancer I'd like to talk about is cervical cancer. This is the most common GYN cancer worldwide. The number one risk factor for cervical cancer is chronic high-risk HPV infection, which is commonly asked on the CREOG exam. Other risk factors include tobacco use, high-risk sexual activity, that includes early age of sexual debut, higher number of sexual partners, and a history of sexually transmitted infections, immunosuppression such as organ transplant or HIV, lack of screening or lack of the HPV vaccine, and low socioeconomic status. We do have the HPV vaccine, otherwise known as Gardasil, for primary prevention of cervical cancer. It's 90% effective in preventing the high-risk strains of HPV 16 and 18. It's recommended to start at age 11 to 12 for both males and females. We also have secondary prevention in the form of pap smears, which are screening tests for cervical cancer. The definitive diagnosis of cervical cancer is made by biopsy. 80% of the time it's a squamous cancer, and 20% of the time it's adenocarcinoma. After you've diagnosed cervical cancer, the next step is to do a workup to clinically stage the cancer. That includes getting imaging, such as a PET-CT scan, and going to the OR for an exam under anesthesia, cystoscopy, and proctoscopy to further classify the stage of cancer. Here we'll talk about the updated FIGO staging that came out in 2018. It's again mostly clinically staged, but it also incorporates radiologic findings. Stage 1 cervical cancer is cancer confined to the cervix and uterus. Stage 1A is less than 5 millimeters in depth. Stage 1B is more than 5 millimeters but less than 4 centimeters in depth. Stage 2, as you can see here, is disease extending beyond the cervix, and it can go in stage 2A into the upper 2/3 of the vagina, or stage 2B into the perimetrium. Stage 3 gets into the lower 1/3 of the vagina in stage 3A, or out to the pelvic sidewall in stage 3B. If you have any positive lymph nodes that you could see on imaging, it puts you in stage 3. Stage 4 is then invasive cancer into the bladder, rectum, or distant metastasis. I want to briefly touch on cervical cancer treatment. Patients are good surgery candidates if they have a small tumor confined to the cervix that's less than 4 centimeters in size. For anything beyond 4 centimeters, or a tumor that spreads to the vagina or perimetrium or any positive lymph nodes, radiation is going to be the treatment of choice. And for metastatic disease, you're going to want to start with chemotherapy. The next cancer I'd like to talk about is endometrial cancer. This is the most common GYN cancer in the United States, and there are two types. Type 1 is the most common histologic type of endometrial cancer and accounts for about 75% of all cases. It is estrogen sensitive, which means that excess endogenous estrogen states, such as PCOS, chronic anovulatory states, obesity, and diabetes, all are risk factors for type 1 endometrial cancer. Lynch syndrome is a familial syndrome that's also a risk factor. Type 2 endometrial cancer is a higher grade with a poor prognosis than type 1 cancer. However, it is more rare. 70% of all patients diagnosed with endometrial cancer are stage 1 at the time of diagnosis, with a 90% 5-year survival rate. That's typically an exam question on the CREOGs. The presentation can be varied, but typically patients come in with abnormal uterine bleeding or postmenopausal bleeding. The first step in diagnosing endometrial cancer is getting a tissue biopsy with an endometrial biopsy that can be done in the office. After you've diagnosed endometrial cancer, you have to do comprehensive surgical staging, which includes a total hysterectomy, bilateral salpingo-oophorectomy, pelvic and para-aortic lymphadenectomy, and collecting pelvic washings. Now let's go over the TNM staging criteria for endometrial cancer. Stage 1 cancer is going to be a tumor confined to the uterus. 1A is less than half of the myometrium, and stage 1B is half or more of the myometrium. Stage 2 is a tumor that then invades into the cervix. Stage 3 then involves the serosa, adnexa, vagina, or perimetrium. Think of it as the cancer spreading outwards first and then down into the vagina. So stage 3A is involving the serosa and adnexa. Stage 3B is vaginal or perimetrial involvement. Stage 4 is tumor invading the bladder or bowel or other distant metastases or lymph nodes. The last cancer that we'll talk about is ovarian cancer. This is the most deadly of GYN cancers, and there's many different types. The most common type of ovarian cancer is epithelial cell cancer, which is 85 to 90% of all cases, mostly papillary serous carcinoma. The germ cell tumors are about 20 to 25%, and those include things like dysgerminoma and yolk sac tumors. And then finally, we have sex cord stromal tumors, making up less than 10% of all the cases, and those include things like granulosa thecal cell tumors and fibromas. Risk factors for ovarian cancer include family history, the BRCA mutation, age, being postmenopausal, early menarche, late menopause, and nulliparity. There are some things that decrease the risk of ovarian cancer, and those include pregnancy, oral contraceptives, and tubal ligations. Now let's talk about ovarian cancer staging. Remember that ovarian cancer is staged surgically, just like endometrial cancer. So you have to do comprehensive surgical staging in order to fully stage ovarian cancer. Stage 1 means that the cancer is confined to just the ovaries. Stage 1A is only one ovary, and stage 2B is B, both ovaries. Stage 2 is the cancer growing outside of the ovaries. Stage 2A is extending to the fallopian tubes or uterus, and stage 2B is actually extending to the other pelvic organs like the bowel or bladder. Remember that for the other cancers we talked about, that is a higher stage than ovarian cancer. Stage 3, the cancer then can grow to the peritoneum or can also include retroperitoneal lymph nodes. You may or may not see the visible tumor in the peritoneum, but that still counts as a stage 3 cancer. Stage 3 can also include cancer growing on the surface of the liver or spleen, but not inside those organs. Stage 4 is the cancer is now widely spread throughout the body. This can include cancer growing inside the lungs, liver, or spleen, and can also include malignant pleural effusion, fluid around the lungs, from the cancer. To finish up, I'd like to go over a practice question with you. A 52-year-old G2P2 woman was recently noted to have a 3-centimeter cervical mass after going to her doctor for postcoital spotting. Biopsies taken of the mass confirmed squamous cell carcinoma of the cervix. Which of the following is an allowable tool to clinically assess her for stage 3C cervical cancer? This question is trying to get you to think about the differences between cervical cancer staging and the other types of cancer. Remember that cervical cancer is staged clinically. So when we're looking at these answer choices, we know that C, a lymph node dissection, doesn't make any sense because that's surgical staging. Then we're left with A, B, D, and E. Remember that stage 3 cervical cancer is cancer that extends to the bottom third of the vagina, pelvic sidewall, or includes any positive lymph nodes. So which one of these answer choices would help us evaluate for any lymph nodes? That's right, it's the PET-CT scan. So just remember that these are the kinds of questions you may see on your CREOG exam. Here are my references, and thank you so much for listening in.